Okay, we're going to take a little interlude away from science, and we're going to, in the middle of our day, we're going to go to the core of the issue, which is the patient, which has always been a focus of this foundation, is to understand the patient's perspective on living with vascular disease and promoting vascular health from the standpoint of everyday life. And to do that, I can think of no one better to do it than Matt Corriere, who's the chief of vascular surgery at Ohio State, but who's worked on understanding decision-making and patient priorities and trade-offs very diligently in a very rigorous fashion. So Matt, let me have you come up, and then you can talk a little bit about some of what the patient experiences we're going to discuss.
Thank you for that kind introduction. Yeah, this will be something completely different, but I would say important. And there is some science to it. So it was a departure from science. We're going to explore patient perspectives. We're here talking about this relationship between metabolic and vascular disease, opportunities for earlier intervention, ways to better mitigate these problems. That's part of the scope of this conference. We're going to have a couple brief patient interviews that are video format, and then we actually have a patient here in the room who's going to come up and share his story once we get everybody loosened up and get through all the basic questions here. What am I doing up here? I am not a card-carrying expert in metabolic disease. I have, with help from Vascular Cures, spent a lot of time looking at patient voice, looking at qualitative inputs into how patients view their treatment interventions under consideration and their outcomes and their goals. I was very glad to be able to contribute to this. And I'll also say, and I worked on this with Mike and one of our patient advisors for this recent guideline update who's in the room. A lot of what we've been talking about all day long has come up in this qualitative work. With this guideline, we were asking patients questions about taking a new medication that's going to make you live longer or keep your leg on longer, but wasn't necessarily going to make you feel any better, just like I think Mark's comment earlier about being unaware of the bad thing that didn't happen. And I got to tell you, we were surprised on this writing group team. There was a lot of wait a minute from the patients. Patients really want to be aware of why they're taking a medication and are not always just going to sign up for an extra medicine if it's not going to make them feel better, without a lot of runway and partnership in why are they on this medicine. And I was reflecting on that as we saw panel after panel of 6 different medications we could put everybody on if we want to have better outcomes. Some general observations I've had with this work is one size does not fit all. Patients are often really pleasantly surprised that we want them to tell us what they think about stuff, and it can be sobering at times to hear patients talk about how they kind of get swept along or steamrollered in a clinic visit and never get to kind of get their word out. And some of the constraints we practice under, the 15-minute visit is something I'm aware of, and increasingly is not really under the control of a clinician. So we need better tools for this stuff. And we've also seen that treatment's often fragmented from the patient perspective. This is a representation of Elixhauser comorbidity. So I also want to remind the group that we're zeroing in on PAD and metabolic disease, but the way our institutions look at risk, these are little pieces out of a really big puzzle. And all these different comorbid conditions can exist in varying combinations that have various levels of influence over how patients do. And in this paper, which I think is a really good one just to explore, is that the more chronic conditions you accumulate with a given patient in front of you, the complexity really starts going up. It gets harder to design an intervention, and it gets harder to pick an outcome you're going to measure. And that's important because none of our patients with PAD tend to have PAD in a vacuum. This is how a simple vascular surgeon, this is from a book chapter I wrote, might look at the treatment equation. Is they got PAD, it's causing slow walking, they're walking impaired, and we do an intervention and it just gets better. But what's really more commonly going on is there's all this other stuff. If they have neuropathy, arthritis, COPD, in addition to their PAD, We sometimes can get blinders on and tunnel vision about firing PAD interventions at someone with multifactorial problem impairing their walking activity, and it's too seldom that we kind of think through all that stuff. So I'm going to pull up the first patient video. This is our first major chance for an AV problem because we want video and audio. I think it's going to take about 30 seconds. Is Emily in the room? Emily, raise your hand. So Emily is interviewing her mother-in-law, and I understand she likes her mother-in-law. Is that correct? Okay. So I'm going to stand back, and we basically had some questions that some of the speakers today contributed as suggested questions about ways to get patient perspectives. And I'm going to step aside for a minute, but my understanding is that this patient is 49 years old and takes metformin and has hypercholesterolemia, fatty liver disease. And so when you think about these phenotypes, they're not on that macrovascular track just yet. And let's hear this patient's perspective.
So for me as a patient was education or lack thereof. Not having the education on the medication, why I needed it, what it was for, how it affects my body, good or bad, that is a big obstacle to overcome. But since I've been going to Casa Colina, I don't have that obstacle anymore. They have educated me on everything, and I feel more empowered to manage my medication therapy. So education is really something that helps patients, helps us. Yeah.
What matters most to you when considering new treatments? Is it how they make you feel, if they improve your walking function or symptoms, prevention of complications like heart attack or stroke? All of these things are important, but as you consider costs, side effects, and multiple medications, what benefits do you prioritize?
If I really need it, if there's any other alternatives out there, side effects are just huge for me. My body's very sensitive, so I really weigh the cost. How effective is it? Yeah, side effects, that's a big one.
And then lastly, what do you value overall?
Effectiveness of the medication, education of the medication, side effects, again, affordability, and yeah.
Okay, any other feedback you would like to give?
Yeah, I would like to say that I'm very thankful to Casa Colina for providing the environment where I can learn and grow as a patient. The information they've given me has helped me tremendously. Understanding medication, understanding diet, and how diet and exercise plays into controlling and managing diabetes. The information has empowered me by going to these classes. I'm very, very thankful for the program. Also, when I first started going to the program, my A1C was at 11. Within about a month and a half doing the diet, they recommend the exercising, watching my glucose, checking it daily. I was able to bring my A1C down to 9 in about 8 weeks.
That's awesome.
6 to 8 weeks time. So again, education and how medication plays into it, how medication can help support. I mean, side effects, it's, if it helps and it supports along with diet and exercise, lifestyle changes, yes, because the goal is to live. So I'm very thankful to Casa Colina for providing the resources. They even gave us these bags of like lotion and socks and diabetes test kits. Just life-changing for me. I went from 11 to 9 in my A1C. So thank you. I'm living. Thank you.
Thank you for your time.
Thank you.
Super interesting there. I understand. I didn't have a disclosure slide. This patient was not compensated for positive feedback for Casa Colina. But I was struck, you could see agency develop in this patient as they gain information about their chronic condition and as they were looking at their own data and sort of taking over ownership of that A1C. And Emily, I don't want to put you on the spot, but would you feel comfortable commenting on anything you saw from this video that struck you as something you didn't know, and maybe one or two comments on that education program, because it sounds like it's a wonderful program, and it sounds like it's a big time commitment, and it's not one that most patients have access to easily. And how did that get rolling at Casa Colina?
Yeah, so that's my mother-in-law. She got diagnosed at, I believe, 49, but she didn't really do anything about it until recently. And for her, it was like very serious to take care of it because her father actually passed away of diabetes. So being able to take care of it and getting a little bit more knowledge and information of how to take care of herself has been really helpful. The program at Casa Colina, which is actually taught by Lupe, has been really helping a lot of people, especially in the Pomona area. And I'm sorry, I don't remember what else you said.
Could you just describe that program she's referring to?
Yeah.
How long is it? How often does it occur? How many people and who runs it?
Yeah, so there's two programs. So there's the diabetes education class program, which is taught by Lupe, which is our diabetes nurse. And that one's every Tuesday of each month, and it's free for every patient that would like more education about it. And then there's another program, which is the limb navigation program, which my mother-in-law is also in. This one is a 6-month program where we follow up with patients and we kind of just give them resources, anything they may need if they want diabetes, like eating healthier, like anything they may need just to kind of help patients.
Thanks for sharing that. I was also struck that she seemed very focused on information and education. We didn't hear doctor's advice. We didn't hear a pill as like the pivot points for her. So super interesting. Any other comments on that discussion before I move to the next? I'm going to keep rolling. This next one is a little further down the spectrum. This is a patient of mine. That's our hemoglobin A1C graph on the screen right there. I just want to say this patient is unique to me in that I've operated on her. The first time I met with her, I was on the faculty at University of Michigan. She lives in the Columbus area, and she showed up in Columbus because she couldn't find a doctor. She showed up in Ann Arbor, drove herself there because one of my partners we had recruited from Ohio State, and she could not get a doctor back home to tell her she needed anything other than an amputation. And of course I was on call and said partner was at Disney World, so I ended up taking care of her. But I've actually operated on her also at Ohio State University. This patient has multiple morbidity. She's my age, which is not old to me yet. I'm 52. And has had at least 8 leg revascularizations, counting both legs over her lifetime, not counting the diagnostic angios. And she had a left leg amputation about a year ago that I performed after she failed her 4th bypass in that leg, and I had to really talk her through that. And when I told Isabel I was going to get this patient to do a video for me, she was pending a 3rd bypass in her other leg. And I want to tell you before I show this video, if you want to go ahead and start queuing it up, I have reservations about doing another leg bypass on this woman. I feel like we're failing. This has like disaster written all over it. And it's one of these ones that her name's on the clinic list and everybody just takes a deep breath because we feel like, boy, we're not making progress here in a really tough situation. And this concept we had earlier brought up of are we doing too much too late? So you ready to go? Her name is LaTanya Wolf. This is an edited video too. The purpose of this is just to get some patient perspectives on folks that have dealt with peripheral artery disease and diabetes so that we can help understand how to formulate treatment plans that are patient-centered?
I'm LaTanya Wolf. I'm age 53. The peripheral artery disease, it came when, after my first surgery that I had on my foot, I had an incision drainage surgery, and I had a piece of glass in the back of my foot and did not know it due to no feeling in my feet. Once Vascular got a hold of me, they realized that I had peripheral artery disease, multiple bypasses, multiple amputations, and then finally my leg got amputated in 2024 November.
How do you feel about your ability to kind of own the management of your medicines? And if there's obstacles with your medicines or your vascular health, what would be the best way to address them?
Then to manage my diabetes medication, I have the automatic Libre on my arm. I think that's the best option because I was really bad at testing my blood sugar. I was going a day or a few days or a day with high blood levels of blood sugar. Now I have it to where once it's high, it's on my phone, and hopefully I'm going to be able to regulate my medication as far as my insulin intake. As far as managing or changing anything, I really don't have any concerns as far as changing my medications. I'm just hoping that the ones that I'm on are going to work. I wanted to be a candidate that could do the hyperbaric chamber. I've heard great stories about that, but unfortunately, for some reason, my Medicare and Medicaid won't cover that. I have a deep wound on my foot. However, they said it's not to the bone, so I can't do the hyperbaric chamber because it's not to the bone. But I feel like it's severe enough that I should qualify for the hyperbaric chamber before it gets to that, point that it's to the bone. To me, that's very important, and to insurance, it's not. I'm willing to try anything to help my situation, but it just depends on the high risk, like that antibiotic that they like to put me on, vancomycin. It affects my kidneys really bad, so I can't take that when I have a severe infection. So that's one high risk thing. I don't want to have issues with my kidneys. I don't want to be on dialysis behind taking vancomycin and my kidneys numbers go down. So that's one risk that I'm definitely not willing to take. I feel like they should be able to come up with a different antibiotic treatment.
What's your biggest goal through treatment? The one thing that's the highest priority for you to achieve?
Open up my veins and be able to walk again on my prosthetic.
And what advice would you have for us in terms of where to focus our effort and how to make things more patient-centered?
I feel like there should be more options now out there before amputation. I ended up going to Michigan. There was a great doctor there. He, did what he could for a year longer before I had my amputation. So that meant a lot to me, because to be told from a hospital, hey, we can't do nothing but amputate your leg, I was refusing at that time. Like, I didn't want to face that. I didn't want to be an amputee. So work with the patient to try to save their limb before it's amputated. I was able to keep my leg for another year, but I had several surgeries. And the healing process from surgeries, as everyone knows, it's not fun. So when I look back on all the surgeries I had and trying to fight to save my limb, in my mind, I'm like, was it worth it? Yes.
Do you feel like your diabetes care and your peripheral artery disease care, do you think those are best done by separate specialists?
I feel like they should be kind of communicating closer. hoping that the endocrinologist can possibly work with my vascular surgeon and kind of, have me do better.
On behalf of myself and the Foundation of Advanced Vascular Cures, I really want to thank you for volunteering your time and your perspective, which is super valuable. And I hope that that's going to help a lot of other patients down the road.
I hope so too.
So this is interesting for me to watch. You can see that she has, on one hand, incredible agency, but on the other hand, is very focused on various elements, single drug that's an antibiotic, how she monitors her blood glucose. I'll also say, we tend to look at that amputation she had as failure. It struck me that she really appreciated having her leg an additional year, even though she didn't keep it the rest of her life. And so I thought a lot of those perspectives were super interesting. We also got to, see somebody having challenges accessing various types of care based on insurance. And, this is the kind of patient that I would empty the tank of resources. This is somebody that has high risk written all over her, and we really are struggling to keep our head above water. She was actually a no-show on the day of her pre-op appointment, so I have not done that extra revascularization on her yet. Thinking just now, looking at the endocrinology comment, I don't know what the environment's like at your hospital. This patient shows up for an angiogram as a glucose of 350 in the holding area. She has an endocrinologist that only sees patients in clinic, does not see patients in the hospital, and collaborating with them really takes a lot of work on my team's part, and we're often, tagging between multiple different physicians that might even be within the same specialty, but are siloed in terms of their practice environment. So a ton to unpack there. She still has this goal of walking with a prosthesis. I hope when I see her next that her foot is not too far gone, and I am still anxious about offering her this additional bypass, but I also was struck by the fact that what may seem like futility to me is not wasted work on the patients from the patient's perspective. And so before we take more questions, I'm going to bring up our in-person patient, YL. You want to come on up? Maybe we can convene together here over at the table. You can YL, meeting him, as a vascular surgeon, I'm basically a geriatric surgeon. So as the years go on, when the patients start looking like me, or maybe like one of my kids, it's very sobering to me over time. YL, maybe you want to just share whatever you would like to about yourself, and we'll open it up to questions. I'd be interested in your perspective on those videos you just saw. And I want you to speak from your own experience and perspective, so we're not asking you to come up here and be representative of the Medicare population in the United States or something like that.
How y'all doing? Well, thank y'all for having me. My name is Wael. I'm 32 years old now, and I've been a patient at UCSF for the last few years. As far as the videos, I resonate with a few of the things they said, and we can talk more about it if people have more questions. But bear with me, because a lot of these medical terms are going to go thrown out the window. I don't know. I'm not in medicine. So I think the biggest thing that stuck to me was the last lady was talking about more cohesiveness with the different doctors and understanding things, because I'll tell you a little bit about my history, but I think just first trying to figure out how to process this or understand what's going on. Like, there was a lot of ambiguity and misdiagnosis, and even just talking to a bunch of different doctors, or even hematology, rheumatology, just getting an understanding and repeating myself, and just why not going to understanding if this was a vascular issue or not in the first place. So first and foremost, I think I've been on this journey since I was 26. And I got diagnosed with APLS along the lines, and just risk of clotting. And at first, it started with me just being active, playing basketball, no surgeries, no allergies, pretty healthy. And then one day just feeling like a cramp in my calf. And then I kind of just dismissed it, and then it just slowly started getting worse and worse, and I kept feeling more and more fatigue in my left leg. And long story short, went to a lot of doctors, my physicians back in San Jose, and they couldn't figure out what was wrong with me. They just said, oh, like, you know, here, take some medicine, take some medicine. Ended up potentially being a misalignment, was going to chiropractor for a while, and was going back and forth with, oh, we really don't know what's wrong with you, but just come again and we'll try to figure it out. And then trying to give me medicine that I wouldn't take. So fortunately enough, like, I switched my primary care physician to someone near my area in Oakland, and they recommended that I see a vascular surgeon or just get vascular consultation. And this is like 2 years into my discovery or trying to figure out what's going on. And then they recommended me to Dr. Conti, and we just kept talking and trying to figure out what was going on. And finally, like, when I got recommended to vascular, we found there was like some plaque buildup, clotting, or like some slight buildup in my femoral artery, and we were able to monitor it and like keep looking at it, be active, and try to see what was going on. We were monitoring it. Conti did a really good job at just making sure he was observant of me. And then I want to say like maybe a little less than a year into it, I randomly just started having super severe pains, and I have a high pain tolerance, so they were pretty bad. And I just remember, like, for 2 days just like trying to thug it out, because I come from an immigrant household, so we're a little hard-headed about doctors and medicine. So I just remember, I never forget it, I tell my family this, like, one day I couldn't sleep at night, and I literally would wake up, go to the bathroom, sit on the toilet just to numb my feet, and then try to go to sleep for 15 minutes. And I would do that the whole night. And then so I woke up the next morning, I was like, I gotta go to the doctor. So went to urgent care at UCSF, and was just waiting in excruciating pain. And then I went with my sister, and then after waiting for a while, they told me, oh, like, this is an emergency. We need to go to the OR right now. And mind you, again, no surgeries, no experience with this at all before. And I'm just like, all right. So I just called up my dad real quick. Hey, Dad, don't panic. I'm at the hospital. I need to perform an emergency surgery. So it went from having no surgeries to getting 3 incisions that day. And we found out that one of the clots in my femoral artery broke down to, I think, my ankle and my calf. So it was a lot of interesting emotion and processing in such a quick time. And, you know, by the grace of God and the surgeons, I was able to recover well. And, yeah, just had to get used to that recovery. Found out that I was diagnosed with APLS at that point, and then going from no medications to having to be on warfarin indefinitely, and then just continuously monitoring my blood clotting INR levels. And so that's where I went from there. After that, things were going smooth for about like a year and a half or so. And then, unfortunately, I started feeling symptoms that were very cognizant and resembling of what I had before. So after that first surgery, just what I learned was I had to be super sensitive to any reactions in my body. Before, I would just dismiss things, but now it's like a little bit more on the paranoid aspect just to be healthy. And we found out that there was some blockage again. And so went back and monitored that as well. And then it came to a point where I was feeling the exact same pain. I couldn't even go to the gym anymore. And I went back to the ER, and fortunately it wasn't a clot, but it was still painful because my arteries were like at less than 30% of blood flow that they needed to be at. And so we decided to try to clean it up and make sure that the buildup went away, and then patch that area like twice or 3 times as much as I needed. So I was like, sure. They mentioned that there was a potential of me getting a bypass at that time, and I was like, I'd rather not. I'd rather use that as like a last resort. And then so we went with the build-up, cleanup, and I was feeling good after the operation for like maybe a couple of months. And I was good for maybe the rest of that year, which was, I want to say, last year. And then, unfortunately, again, I was feeling the same symptoms. But fortunately, this time, I was monitoring it very carefully, talking with Conti, and we decided, I thought about it a lot, and I decided to do something more proactive, and I wanted to get the bypass because I was like, it's my best opportunity of longevity, of like a healthy leg. And so we had a lot of conversations about that, and just recently in March, I ended up getting my iliofemoral bypass. So like really fresh, been monitoring it really well. Dr. Conti and his team has been really helpful with me. And so that's a long-winded way of showing you where I am today. But yeah, it's been a journey. It's been a lot of lessons. It's been humbling. And I think the most important thing for me is just to, take it day by day, but also I've been keeping a super positive mindset on it because I'm just looking forward to any advancements, but also just like having a quality of life that I feel like we can all take for granted at times.
Wael, before we open it up to broader discussion, if you could go back in time and talk to yourself the month before you had that first pain after the game and went to the doctor, what advice would you give yourself? What do you know now that you'd wished you'd known? And what advice would you give to those doctors who were seeing you before you got to the diagnosis? Because this concept of delay in diagnosis, delay in initiation of treatment is one that comes up often with patient stories.
Yeah, I would tell myself to buckle up. But no, in all seriousness, I think it's hard for me to say what I would do for myself because I don't really know I could have done anything more because I was exhausting all my options. And when I'm particular about something, I get very particular. And I would just say, like, hopefully in the future, other doctors will be cognizant of if there's certain issues, we should think of vascular first. Or if there's certain symptoms, we should know these are like pretty big indicators of something that we should refer. Because if I hadn't switched physicians, I would have probably still been in this limbo, right? So I was blessed to just make that decision. And so I think that's the biggest thing that I would take from that.
Open it up, comments or questions from audience members?
I had a question on, did you, I'm a patient also here, so, and there's a lot of online information. Thank you. One of the things that you were proactive, went to see a doctor. I just, we were talking earlier with Dr. Matt there about there's such a proliferation of online information that, like, as soon as whatever, not me necessarily, but people go out and look and try and find all this, and it can be so misleading. And I just want to know what your experience is, because for me, I try and find the sources of the information, but it's a rabbit hole, right? And some of it is kind of like this conference where it's like, whew, like way over my head. But there's nuggets of good information there, right?
Yeah.
And I just wanted to know your experience with your condition and what outside information maybe led you astray or didn't, or led you to the right place.
Yeah, that's a good question. It's like, we got ChatGPT now, but a big thing back then, it was like WebMD. And so, like, you're looking for a pasta recipe and you find out you might have cancer, right? So it's like, it's ridiculous. So it was a lot of unknowns, right? So, like, even sometimes I was like, oh, should I be doing this while taking my medication? Or what are the things I have to watch out for that, maybe are unconventional, right? And you see a lot of forums and a lot of people like giving you like pseudoscience advice. I would just say like, first off, I would just consult Conti. Like, I feel like sometimes I would just bug the team. Like, I'm like, I don't care. I need to make sure that like, I'd rather be safe than sorry, right? And so I tried to take everything with a grain of salt because, again, like, everyone's body's different. So like, just because something worked for someone, it's not necessarily gonna work for you. And so like, even for me, like having to go through this multiple times, right? Like we were hoping that the first time would be a sure thing. Like, I don't know what's going on with my body, but my body's just doing what it's doing, right? So I would just say like, I was taking everything with a grain of salt. So I would get some information here and I'd be like, oh, you know, like if it's not too impacting and if I feel like it will work for me, let me try it, consult with my doctor and then see if it helps, right? Or if someone was saying something and like, there was no legitimacy for it, or even honestly, like the tone of how they were saying it, right? It's like, I feel like if you carry something out like a negative way, it's gonna impact your body physiologically. And so like, I was just taking everything, like making sure I took perspectives that were relatable to me and not taking everything as truth, taking everything and just analyzing it myself and like being realistic of how it would help me. But yeah. I think being positive was like a huge key though, like more so than the information I was getting. I was like, this is a big unknown and I'm just like hoping to get more answers even continuously right now. And so hopefully we can find more answers that are not on the web.
You have another?
Am I going first? Yeah.
Oh, thanks. Hey, Lyle, Dave Griffin. I'm a foot doctor from up in Portland, Oregon. Thank you so much for coming today. This is extremely valuable and to share your story and your vulnerability of what kind of happened along the way. I had a question for you about the hard-headedness, if you will.
Yeah.
We're always trying to find ways to encourage people to come in when they're having a problem. And I wondered if there was a particular barrier or concern or worry that led you not to want to go back to see Conti after you'd already seen him before and you're sitting on the toilet at home and your legs are hurting you? Was there, if I got that story right, I'm just wondering what kind of, I guess, like you said, the immigrant mindset, maybe I'm tough, I can get through this, but is there something we could have done differently to help you to feel more welcome or accepted to come in?
That's a good question. I think not necessarily. To just be transparent, it's like even in a lot of communities, the trust between medicine and what you really need to be done is very rough. So it's kind of like if I need it as an ultimatum, do it, go to the doctors versus be proactive like I did at the end of my journey. So I think personally, like, Conti has been a godsend for me, and he's been very easy to work with. So I don't think it was anything on his behalf, but it was more so of a mentality thing. And I think it's just opening the trust between transparency between medicine and patients, because even in my own experience, I've seen a lot of patients have issues with like going to get consultation and getting the wrong answers. And like the lady that was talking right now, like getting a amputation resolution before it was actually needed, and she found this great man over here, Matthew. Like it's tough to trust at a certain point, and we just need transparency and like making sure that we feel comfortable with you knowing that you're doing your all to give us the right resolution.
Yeah, that really resonates with me because I work in the community up in Portland. I think that trust, I think we've talked a couple times this morning already, but it's really the heart of the issue for a lot of people, I think, and the willingness to re-engage with the medical community, particularly in some of the underserved areas, particularly the African-American community. I see it a lot in Latino community as well. And I think it really resonates to me to remind me that we need to spend that time to build that trust at the beginning, so you know the old saying, you don't care how much they know until you know how much they care.
Yeah, so that's a great thing. And I'll add one thing to that too. It's like, this is my perspective because I had a friend who went through the whole medical school process, and I was with him, and he actually studied under Conti. You know how to resolve an issue, or you know how to find the textbook answer to something, right, from your perspective. But the empathy is just so important with patients, right? And like that more so is more important sometimes than you giving them like a straight path. It's like, can I trust you? Are you here for my best interest, or are you here just to like, all right, I found the resolution, next person, right? So getting through that and bridging that is just the most important thing to do. And I feel like it would be ideal if every doctor just focused on that rather than how can I solve this? Like, how can I make you feel comfortable with me solving this?
So hi, my name is Lupe. I'm a diabetes educator at the wonderful Casa Colina. So I just wanted to kind of give my little bit of input as far as diabetes education. I mean, it's documented that it's very underutilized, right? And we keep talking about, how to communicate with patients, how to have that more time, right? Physicians are very limited with how much time they can spend with their patients, and the educators have a lot more time. So, when I work with patients, I can ask, why are you not taking your medications, or what's the barrier here? And it can be emotional, it can be mental, it can be fear of medications, it can be, all these different things that physicians don't usually have enough time to really dig into. And so like my class is supposed to be 90 minutes, but it so often goes over, it ends up being a 2-hour class. My class was, a once a month, like a one and done type thing, but we had so much more, need, and so we turned it into a two-part class, which is actually in the process of, we're probably going to turn it into a 3-part class, just because people want more and more and more of that education. And it's really explaining the why. I get so much. I mean, Emily's mother-in-law, like, she was such an awesome class participant because she just had all these light bulb moments of like, oh, that's why my doctor said this. And then explaining, this is how this medication works. This is why you get these side effects. And it's like, oh, now I understand why metformin needs to be taken with food, right? Now I understand how it's working. So that adherence, that compliance, right, to their medication really just shoots way up when they have that education to make them feel empowered, right, to make them really take control of their disease process, right, of their diabetes. And so I just kind of want to like really throw that out there because I know diabetes education can be a hard sell for hospitals or places to implement because it costs more than you can bill for. So I know financially it can be hard to implement. We were very, we got the limb preservation grant, which is how I came about to Casa Colina. But there's studies that show that diabetes education lowers A1Cs, sometimes way more effectively than medications itself. And also, you save money by the lack of readmissions and all that stuff, right? So I just kind of wanted to highlight that maybe that's something that your hospital, your medical facility hasn't really looked into that might really help a lot of people because it really empowers the patients. And when they're empowered, they do a lot better.
Yeah, that's a great point. That reminds me of something too, to the previous question as well. Money too. Like, insurance is great, but I feel like the amount of help and support they give you year by year just declines. So if you're gonna make a decision like a surgery, it's like, do I need this? And if I don't need this, why would I go in and waste money? And it's, we could talk about insurance in America, but that's another story. And so it's really thoughtful to think about like how to maybe educate more and understand that these are things that are going to help you in the long run and save you money, right, to that point. And then also I think the longer that we get educated and the more I know, I'm trying to help others too. And I think a big thing is positivity and word of the mouth, right? So because of my experiences at UCSF, when people are talking to me about like issues or trying to get checked in, I'm like, you should try UCSF because I've had a great experience. So the more great experiences and the more interpersonal you get with people, I think the better the outcomes will and the trust will break down.
Mike?
Well, I wanted to also thank you so much for coming and being willing to share your story with this group. It's very empowering to people, and I think thank you for doing that. Part of it, was because why I asked you is because you did own this so much, and there's quite a range about how much people want to actually own about taking care of their own health, or how much they want packaged for them. And now you've learned that you have, it's not the most common reason to have vascular disease, APLS, but similar to diabetes or hypertension, it's kind of silent until you have a problem. And now you understand that there's potentially some sort of slight problem in your clotting from this problem that requires you to manage it long term. And you're taking the medicine that requires you to pay attention to your diet, and you have to go in and get blood tested every so often. So I wanted to ask you what your thoughts are about, right now it's pretty acute, but you're looking at, staying motivated around the medication and the monitoring for a long time, and also how different people's attitudes might be, and what you would wish for in terms of a treatment or a medication that would make it as easy as possible compared to, what you're looking at.
Yeah. Thanks for that. He's the man, by the way. As far as regulation, I think that's something that I feel like that's the biggest struggle for me. But I think I've gotten into a habit of understanding and making my appointments to get my blood drawn. I wish that would be more easy to access versus like sometimes I would try to meet with the anticoagulation clinic, and it would be hard to get an appointment to get my blood drawn. So then sometimes I'd have to go from here to SF to Oakland, or try to find certain areas at a certain day. And so I know there's like in-house options, but I think they were telling me like they're inconsistent and it doesn't apply for me. So any way to make my blood draws more accessible, or even like the medication in the future to be more consistent and give more longevity for stable INR readings, I think that would just provide so much use for me. And then, I feel like that would also provide more confidence and from the spectrum of patients to be like, okay, I can manage this. I don't have to do this so often, and it's less frequent, so it can be easy to remember and not be too hard on me, because it does take time from your day. And like sometimes I do have to take breaks from work to make sure that I do get my INR readings checked.
I think we can wrap up. Do you have a comment, or are you just okay? Again, let's give them a round of applause. This is an intimidating experience.
I appreciate it.